the third talk from Mr. David Laraway. Now, David is a consultant maxillofacial surgeon and with a strong interest in craniofacial surgery and reconstruction. After completing his training, he did a fellowship at Alder Hey. He's the OMF lead in Glasgow for trauma. And I think, as you'll find from his talk, he has a real and genuine passion for cranial reconstruction after head injury. And he's talked both nationally and internationally on this subject. So if you can join me in welcoming Mr. David Laraway, please.
Good afternoon. Thanks for the very kind introduction. It's really great as a max fac surgeon not to be introduced as a dentist, because that is fundamentally what we start out at and is how we're often introduced. So thank you very much. And obviously thanks to Digby Brown for putting on this excellent meeting. I called my talk the final piece in the puzzle, and in many ways that's disingenuous, because the final piece is the ongoing rehabilitation and rebuilding of people's lives after these injuries. But this is sort of the final part of the surgical puzzle. I also have a really great interest in highly complex jigsaw puzzles. So what am I going to talk about? I'm going to talk about the importance of putting the box back together. And it's got two functions, really. So part is that it normalizes the appearance, which is of huge importance to the individual, to be able to blend into the crowd again. And also there's a functional element to having that box closed, and I'll talk a little bit about that too. I'm going to talk a bit about the service that we have in Glasgow, because I'm really proud of the service that Michael's involved in and that many of my other colleagues contribute towards. I think we're doing quite interesting stuff. I'll talk a bit about some of the challenges that we face and how we deal with disappointment. And that's not just my disappointment, which is often present, but the disappointment of these patients who've been through such a lot before they ever get to my clinic, and having to deal with the reality that these are really high risk and complex procedures that we're talking about. So we've heard a bit about traumatic craniectomy. I'm not going to talk about that again, but what I will talk about, you've heard about the blood element to having the box open. I'm going to talk about the cerebrospinal fluid, the CSF, because I think it's dead interesting. And I think having that box open is very interesting. We've known for thousands of years that if you trephine a human skull, so if you go back to Incans and Mayans, they used to drill holes in people's heads just with hand tools because it changed the person. Sometimes it made them more spiritual. Sometimes it just changed their general personality. Obviously, sometimes it killed them, because I don't think they had very clean tools. But there's a long-standing tradition and knowledge that trephining or trepanning skulls has a global effect on the person within, even in the absence of direct brain injury. So that's very interesting. And it's because this flow of the blood and the cerebrospinal fluid has a key involvement in the supplying nutrients and electrolytes to the brain, therefore the way it works. Very, very important. So it makes, it's common sense that the bigger the hole, the more likely you are to get some sort of effect. And the effects are very, very unpredictable. So they call it a syndrome of the trephine, this selection box pick and mix of weird symptoms that people get when their skull is no longer a closed box. So when the box is open, the flows are wrong, and some people get these odd symptoms. And what are these odd symptoms? So sensory motor things, weird feelings in their hands and their legs, not quite managing to move the way that they used to. A feeling of cognitive decline. So they have their horrible injury, they get better, and then they just gradually drift downwards. They can get headaches and tinnitus and dizzy and exhausted. We've heard a lot about fatigability already today. And unusual pains or discomforts or feelings around the site where the bone's missing. And it's also associated with depression and anxiety. And it's really underdiagnosed and under-recognized. And you can see why. It's a selection of symptoms, some of which could be attributed to going through a life-altering injury. But the weird thing about this is when you put the skull back together, when you close the box, these symptoms can improve, and they can improve quite quickly and really dramatically. And there was a long sort of history that people thought you only got this syndrome in the people with the sunken skin flaps. So a nice picture earlier of the person with the forehead missing the sunk skin flap, but actually it can happen in anyone with the open box. We shouldn't underestimate appearance change. The forehead missing is a classic image, and you get the big side, all the bones being taken away. Very dramatic appearance change, and people don't like it. They don't want to go to school to pick up their kids. They're frightened that they're going to get a bump on the head, and that's going to cause more damage to the brain, and that increases these symptoms of low mood and depression. So we really want to get on top of this. So in an ideal world, which we do not live in, once you've got your head injury and you've settled down and you're feeling better, then you can, if you've managed to keep the bone and you're in a place that allows you to do that, because there are geographical issues around that, then you can replace it. Great. But that doesn't happen often. So if the bone is shattered, or you're in a place you're not allowed to keep the bone, or the bone gets infected, then it's coming out, and you're gonna have to think of something else. And you can't immediately reconstruct all of these things. Implants take time to make. If you've had to lose the reconstruction, your own bone, because it's become infected, or your skin's broken down, or because you know, loads of different reasons, then you're gonna have to wait for that healing process to go, because you definitely don't want to put an expensive, large reconstruction in if there's still infection, for example. So we just need to be a bit mindful. So when do I get involved as a face, mouth, and jaw surgeon / dentist? So I tend to deal with the cases that are pretty awful. So people who've had multiple previous surgeries, multiple failures, the skin's highly compromised, the patients are highly compromised. Basically, it's not going to be fun. And I'm also involved when it's really important to get a nice aesthetic, because being a MaxFax person, we get really, really hung up on how people look. I spend a lot of time trying to normalize appearance. As a side interest, which is actually my main interest, if they've got other fractures of the face, I do all that reconstruction as well. So eye sockets and cheekbones and jaws and things, I'll do all that. But in this context, we'll just talk about the head. So who are we? Well, you've met Michael already, and you've heard about me. We've got another neurosurgeon, Mr. St. George, and we've got a couple of colleagues, John Biddleston and Ollie Mitchell, who are free flap reconstructive surgeons. I'll talk about that in a little minute. And we've got this particular subgroup because we need some neurosurgeons because they look after the brain, and we need some free flap surgeons because sometimes we need to take extra tissue from somewhere else in the body because they've simply run out of skin on their head. So we need a couple of them in case one's on holiday, and you need somebody like me who's just sort of slightly obsessed about these things. And the ethos really is we're all doing something that we actually like doing. So neurosurgeons like brains, and they're good at protecting brains. Marvelous. I'm not a neurosurgeon. I like being close to the brain, but I don't want to be in it. Nothing personal. I like being really attentive to the soft tissues and getting the patient to look like a patient again. I'm a free tissue surgeon, like doing free flaps. I'm just going to explain briefly what a free flap is. So you can't put a skin graft onto titanium or plastic. So if you run out of skin, you need skin or muscle to come with its own blood supply from somewhere else. So you can borrow something. So you can take out a muscle from the back with its blood supply, disconnect it, and then connect the blood vessels to the head and plop it on. So we call it a free tissue transfer, and it's really, really helpful in people who've run out of skin. So a typical referral, head injury, previous craniectomy, they've lost their bone due to infection. Often they've previously had a titanium cranioplasty, and that might be so a reconstruction made of metal. It may have gone in a week ago, 6 months ago, 20 years ago, but now it's come through. And the challenges of those cases are, if it's come through the skin, you've lost skin. So there's already not enough to cover it up. They've probably got bugs in there, so we need to clear up the infections. The more surgeries they've had before, the worse the scar is going to be. The skin's going to get thinner and thinner and thinner, and more likely for the material to come through it again. And internationally, they talk about a 20 to 30% complication rate from cranioplasty. That's a huge complication rate. I mean, if somebody said to me, I'm going to do your hernia repair, and you've got a 20 to 30% chance it's going to go wrong, I would be a bit twitched about that. If they said you've got a 30% chance of dying on the table, I'd be like, oh my God. So it's really big, and it's mega expensive. So the Liverpool group did some sums. It was back in the noughties, so it's going to be 50% higher now. But over £100,000 per failed cranioplasty in theatre time, materials, hospital time, intensive care, the patient not being able to work, and all of those knock-on effects. So it's massively expensive. So my patients are hilarious. They're universally fun people because they are survivors. They've been through such a lot, and they've made it through, and they have reached that point where they just want to get better. They come in and they all say, this is the last thing. Once I've got this on, I can move on, and that's me. Which is a lovely position to be in, to try and help people like that, but also I have to be really honest with them and say, this is going to be really tough. It's really tough, because I'm going to put a big piece of metal or a big piece of plastic or something underneath that terrible, terrible skin that's had 13 operations already. And there's real risks. So CSF leaks, brain damage, seizures, about a 2% chance of not surviving. So it's not tiny surgery. So what do we do differently? Got a good team, and we try and anticipate the challenges rather than just reacting. We're using some new surgical techniques, so we move the scars around. I'm doing different incisions. We're using different materials, and we're standardizing our approach. So we're using the same antibiotics. We're using the same type of head bandaging. We're timing the reconstructions the same way, and we're able to collect that data and say, well, that's working, that's not working. And because I am somebody who moves soft tissue around, we can do new things. So a couple of weeks ago, we used somebody's temporal muscles, so one of the muscles you can chew with, and I just disconnected it and popped it on the top of the head, on top of the implant, because his skin was so thin, I just had no other way of, I wanted an extra layer of insulation, but with its own blood supply. So you can do these things, you can be reactive if you've got a selection of experience on the team. So we'll have a look at some pictures, because everybody loves a picture. So this is my sort of typical patient, hurrah. I don't know why no one else doesn't want to do my job. So very typical, implant went in 20 years ago. And he's been minding his own business, and gradually the skin's broken down. And you can see multiple areas of exposed titanium. It's not grossly infected, believe it or not, because the bugs can get in and out. So there's no collections there, but the skin's wrecked. So I can take that metal out, but there's no way I can stitch the skin together and put another plate in. Just no way. So we did a free tissue transfer. So we took some skin and muscle from his back, and we popped that on his head, And we also did a little rotation flap, so we made some extra cuts on his head and turned it round to cover up a bit more of his head and give him a bit more hair, and stuck some titanium in. And that's his CT scan. Sometimes we do other things rather than just putting titanium in. So this is somebody who's also lost skin and he's lost bone. So he actually lost bone from the lower one. And what we did was take the whole skull out in a new site, a safe site, and you can split the skull like a custard cream or a bourbon biscuit or an Oreo, for those of you who are too young to remember such things. And you can take one bit and put it in the defect, and then you can just put the other bit back in. So it's half the thickness, but it will grow back into a full thickness piece of skull, a split calvareal graft. And then we put free tissue transfer onto him, and that's what he looks like. That's the back of his head. We're also using some new materials. So we're using a thing called hydroxyapatite, which is a synthetic bone substitute. They bake it like porcelain. It's really cool. And when you're putting this in, you don't use plates and screws, you sew it in, and the bone itself grows into the new implant, so it becomes part of the patient. It osseointegrates, to use the fancy word. And it's great. It's not for everybody, but it's a really terrific material. So, have what we do in Glasgow, has that made a difference? So I've got long-term data on 31 cases so far. We've done more than that now. And they've had an average of between 0 and 7 operations. So quite a lot from all different pathologies, so not just trauma, some cancer patients and various other things. But what they all have in common is that they're all complex. So they're all complex because they've had loads of surgery, multiple failed reconstructions, or humongous defects. And we've done free flaps in 7 of them, and these sort of turning bits of skin around in a couple of cases. And we've had some complications, which is acceptable, and they're almost all in the free flap cases, which are, as you would understand, by far the most complex of these. And our non-free flap complications have been very few and far between. We had one hematoma, so a blood clot that required the plate to come out. And we had one guy who got mind-bogglingly drunk 12 days post-op and was found in a ditch with his scalp split open. You know, I'm kind of a glass half full person, so I think he must have had a great outcome to be out on the piss 12 days post-op. So it's still a win for me. The free flap complications, we had a couple of plate exposures, one mild infection in the neck, and one bit of scalp broke down. So actually our complication rate's pretty decent, it's 13%, which is better than the sort of internationally accepted. And the international acceptance is for people having the first go, and our cohort is not first go. We've got a high complication rate in the free tissue ones, which is normal. And only 2 of our patients have not successfully undergone reconstruction at this time, and they are mainly due to social issues. So, new materials, very useful. We found that nicotine is the problem in all of our cases of plate exposure. I don't mean fags, I mean any kind of nicotine, so nicotine patches, vaping, every single one of them has been a heavy user. That's an interesting thing. And they always get an upper limb of the wound, so when you get your wound, it's usually a hockey stick shape, and it's along that top line that they always break down. So we've changed our surgical approach, and we don't open that unless there's a very good reason to do it. We do a different incision. So we've sort of modified all of our practice to improve outcomes, which is lovely. So that's all about me being surgeon-y, about surgeon stuff, but actually does it make a difference to the human being sat in front of us? So I'll tell you about one lady, because she's kept me up at night so many times. So we put a hydroxyapatite implant in her. But her problem was she did a massive decompressive craniectomy. Plate had become exposed, she'd had multiple surgeries, got referred to me, and whenever her skull's not intact, she gets a dense left-sided weakness. So she can't use her arm, she can't use her leg, she couldn't walk, she had to stop working, she became profoundly depressed and had suicidal ideation, and she had to tolerate stopping smoking, and she didn't like it. But I refused to do any more surgery on her until she'd stopped smoking. And she did. And I know because she's twice the size she used to be now. She's come in, she was depressed and big, and she's like, but we put an implant in her. We did a free flap on her because she'd run out of skin. And within 2 weeks, she started to get her movement back in her arm and leg. And she's now quite a long way down the line. She's not walking with a stick. She's actually back working again. She's back out socializing again. So, yeah, it does make a difference. I don't get paid by any of these people, but I am going to say thank you to them. University of Glasgow gives, I'm an honorary lecturer there, so I get a student discount card, so thank you to them. And it works at Burger King, love it. But yeah, so thanks to everybody for pitching in and for my superb team. And I'll